But now let's get to epidural hematoma. So how is it with epidural hematoma? So how is it there? What is the cause? What are the important hallmarks of epidural hematoma, guys? So, very good. Over here, the point is that very likely there's a fracture of the skull on one side, and the meningeal artery climbs on the skull, okay? And as it is torn, as the fracture goes, the fracture torns the meningeal artery, middle meningeal artery. That's typical, okay? So what happens is that here's the meningeal artery and it starts to bleed and causes what? Typical CT scan shows a lentil, okay? Yeah, like that. Why? Because this is epidural, so the bleeding is on the top of the meninges, okay? And why this is important? It means that there's nothing below the meninges, nothing happens. So the brain is sort of covered and protected by the meninges, okay? That's very important. So typically it's due to this, so you don't have a contusion, rather not, okay? And you have only epidural hematoma on one side, typically. And by the way, is there an epidural space? No, exactly. So this is due to that the pressure of the blood slips over. Normally the meninges are glued to the wall, to the skull, and this just opens it, the pressure opens it and pushes it out. So very important thing is dura is safe and is protecting the brain. But anyways, again, over here it depends how big is the epidural hematoma, and what you're looking for is, again, are the middle structures. So, and typically if it's a big epidural hematoma that needs a surgery, remember, you will see a shift. You will see, for example, that one of the ventricles is smaller, and sometimes it disappears. So when you see this on a CT, immediately you have to do surgery, okay? Yeah. Also on the clinical evaluation of the patient. But anyway, so over here, now epidural is what side? This is the right-sided. So what would you expect in this patient that has what problems this patient could have typically? Okay, but rather, of course, yeah, but rather, this is a big hematoma, so typically left-sided, at least left-sided hemiparesis, like the whole left side, okay? Very likely, but watch out. Still, before we get to this clinical thing, how is it with epidural hematoma and it's like someone hits him with a baseball bat or whatever, so, or hits himself, So how does it look like clinically?
Very fast.
It's very fast, but what happens with the patient? Could be, but typically, and this is classical with epidural hematoma, first, he's unconscious for a while, you hit him, he's unconscious, and what happens then? Wakes up, and he's fine. And suddenly, in minutes or tens of minutes, again falls into coma and you're not able to, or it could be hours, depends, okay? But during these hours, suddenly he can lose a laterality. Suddenly he's not able, in this case, he would have, if it's a right side, yeah, it's right side, so he's going to have left side in hemiparesis, okay, yeah? And he doesn't have to notice because he's, for example, on a bed. So that's why you always go, if someone got hit, was unconscious, and tell them to put the hands up. And suddenly they say, oh, I cannot move my hand, okay? So you have to be checking this out. But anyways, first of all, the first few minutes that he was unconscious, what was that? What is that? He was unconscious and then it woke up. That's concussion, it's knockout, okay? But the rupture happened over here of the meningeal artery, and now it's building up. And now it depends how big is the rupture, how fast it expands. If it's fast, he can stay in a coma okay, already, if it's very fast expansion. But if it builds up a bit, then you have this, and what do you call that? It's a lucid interval, okay? It's a lucid window or lucid interval. So remember, especially with epidural hematoma, you can have a lucid interval when first you have a concussion, and then you fall into coma due to the buildup of the hematoma, okay? Good. By the way, yeah, you can have a small epidural hematoma. If you have a small one, like small lentil over there, and you are totally neurologically fine, so someone, I don't know, you had an accident, you were unconscious for a few minutes or seconds, then they put you on a CT and they see you have a small epidural hematoma. But if it's very small, like this, and you're checking the patient all the time neurologically. If he talks, he's totally like in full control oriented, and there's no lateralization. That means that the both arms and legs are moving in similar way. He has the same strength. You won't do anything, okay? So you leave it like that, and if the middle structures are not moved, and remember there's a rule of 5 millimeters typically. So if the shift of the middle structures is lower than 5 millimeters on a CT, and he's neurologically okay, you can leave him like that, okay? So, and this is going to resorb or whatever. So remember, lucid interval is a very crucial term, and that's very typical, okay? And typically, in most cases, you have just the epidural hematoma. In some special cases, again, it was an accident, so in some cases, you can have contusion there, somewhere, small one, but if you check it's much lower probability, okay? So basically, in this case, the only problem that the brain has is the increased intracranial pressure and the compression one side. So again, you can see that suddenly he's losing a control of one. If the epidural hematoma and the pressure increases slowly, he can be awake, but now suddenly not be able moving with one arm, and as it increases more, he falls into coma. Okay, yeah. So you can see this degradation of neurological functions.
How long does this lucid interval last usually?
Depends how fast. It can be minutes typically, few minutes. But I saw someone like for 1 hour or two. Okay, but again, yeah. Remember, for your own safety, if someone is unconscious for a while, and and he's drunk, this confuses a lot. So typically, people in ebriety, they have accidents, and now this is like crucial for you. So they bring him to your department. You're checking out, he's fine. But anyway, sometimes if there's an anamnesis or patient history that he lost consciousness, for your own safety, it's better to do a CT. Okay. Yeah. And if there's nothing, okay, it's fine. If there's nothing, you can let him go. But if you won't do a CT, you have to check him all the time. There's to be someone checking him that he's neurologically fine. Because anyways, again, and I'm repeating myself from the last year, the best way to know how the brain is functioning is to just ask the patient, what's your name, whatever, and movement. That's very important. So that's why you're checking this all the time. Okay? After a head trauma, definitely. After any concussion, you don't know. If it's only concussion, fine. But it could be concussion, but you don't know till you do a CT because there could be contusion, okay, inside the brain. Yeah? So, and sometimes you have contusion and he can be awake, although it doesn't have to be, the patient doesn't have to go into some unconsciousness, okay? So, that's epidural hematoma, but still, surgery. What do you do with the surgery? So what's the hallmark of this? So let's say the epidural hematoma is big, it's expanding, so you have to do immediately surgery. And this is a better outcome than the next one we're going to talk about. Remember, epidural hematoma is always better prognosis than subdural. Subdural is much worse. But again, 30 till 50% die, okay? So I'm just making up the numbers. But anyways, what's the crucial of this surgery? So if I'll draw it here, this is a patient. So the crucial thing with the epidural, and that's a big difference. With the epidural, you do a CT, and you will be opening the skull only above the hematoma. So you will sort of find it out where it is. Of course, you cut the skin, and then you do 4 bar holes, and you take out the bone, okay? And when we're taking out the bone, you immediately see the hematoma. They are coagulums, and you take them out. But the trick is over here that what you're going to do is, so you take out the hematoma, you coagulate the meningeal artery, which is bleeding over there. But the important thing is, and that's why we talked about it, is you have to suture the window that you opened, that you have to suture the meninges to the sides of this opening. So basically, you put a thread and you suture, you go through the dura a bit, like just part, and you suture it within the window. Why? Because secondarily, if it would bleed, then, of course, as I told you, it's an artificial space. So now it's going to be sutured to this, so there's no chance it would expand farther, okay? Yeah. So that's an important step of the epidural hematoma surgery. So you're suturing it to the bone, and then what? You return the bone. Because remember, epidural hematoma, it's not within the brain. It's only on the top of the meninges, and also because the brain is not impacted, there's not just such a huge increase of intracranial pressure or edema of the brain, okay? So that's a big difference. So typically with epidural surgery, you return the bone, you suture the skin, and it's done, okay? Fine. In contrast to this, we get to subdural hematoma. So, thanks for watching, and don't forget to subscribe and ring that bell. And as always, check the description below for supplementary questions and other materials.